I'm really happy to be here. I was really excited when I was asked to come here by my Director General. However, he didn't tell me, well, first of all, he told me it was Rio, and how could I refuse? I've never been. And then he told me there could be a lot of people in the room, and then it was too late. So here I am. So I look forward to talking to you today, and also I look forward to hearing from you and everybody else about what's happening in primary healthcare in your country. We're going through some changes again, but I've been asked to talk about, okay. It switched already. Okay, I've been asked to talk about the overview of the healthcare system very briefly, and then I'm going to talk about a fund that took place between 2000 and 2006. It was a fund that was put forward by the federal government. It was funding for the provinces to transform their system. The primary healthcare system was a specific focus. So I'll talk about that. Even though the fund is over, we're still having some impact of it. And then I'll talk about some of the current direction in primary healthcare across Canada, and you're going to hear a lot of very similar things to what the UK is experiencing and some of the things that we want to look at as well. So I'll start there. Okay, and I point at the table. All right. So Canada's health system is a bit different than UK's. It's not centralized. It's a shared system between the federal government, the provinces, and the territories. And we describe it as a set of interlocking health insurance plans. Overarching that is legislation. It's the Canada Health Act that was passed in 1984, and it guarantees 5 things for the Canadians. No matter where you live, you have universal access to hospital and physician services. And just keep that in mind, because as I move forward, that issue around just hospital and physician services has become one of the areas that people are trying to look at. It must be comprehensive, and it must be publicly administered. So if you live in Ontario and you move to Saskatchewan, you are guaranteed the same type of level of service. Okay, point there. As the federal government, we're one of the funders, and we're also a leader in funding research into new types of healthcare models. We do research, collect data on the populations that we feed back to the provinces. We also have the Public Health Agency of Canada, which is responsible for public health, such as influenza. It was one of the leaders that worked with the provincial public health organizations when we had the SARS crisis. We administer what we call the Canada Health Transfer. This is a large amount of money that we transfer to the provinces for healthcare. It must only be used for healthcare, and it's part of the legislation in the Canada Health Act. So in order to receive this funding, provinces must adhere to the 5 principles that I mentioned before. We also are a regulator at the federal level in another branch, nothing to do with me, but regulate food safety, medication, medical devices. And then we provide services to the Aboriginal populations of Canada, like here, we have First Nation and Inuit. But the deliverers and the planners and the people responsible for healthcare service delivery in Canada is actually the provinces, except for a small group of population, as I said, the Aboriginal communities, and also the military and veterans. It is, that's federal. The rest of it is provincial. And so they are responsible for the priorities they set, how their services are delivered, who delivers their services, and where those services are delivered. Our role is to transfer money through taxes to assist them in this, but also we provide leadership sometimes, depending on the situation, when we use targeted funding to help the provinces transition. Okay. I'm not going to spend a lot of time on this, but just showing you in 2011, Canada spent $200 billion on healthcare. We are in a situation of economic constraint at the moment. The federal government recently made an announcement. We will continue to increase the Canada Health Transfer by 6% till 2016. After that, it will only be raised at the level of inflation, and also depending on the economic situation. This has caused some of the provinces to be concerned. They have seen rising healthcare costs, and they're worried about how this is going to play out. Okay. Oops. The only thing I'm going too far the other way. How do I go back? Oh gosh. Okay, they didn't say I had to be technical either. I think I'm going back here. Shoot. Here we are. Hello. So, expenditures by use. The only thing I wanted to say about this, even though you waited for this big graphic, the only thing I wanted to highlight was in the mid-1970s, hospital spending was about 45%, and it's now down to 29. So you're seeing a shift on where the money is being spent in the Canadian healthcare system. The second largest proportion is drugs, medication, and this is definitely growing and is causing a lot of concern as well. And then the next portion is physicians. Excuse me. Okay, so primary healthcare in Canada is seen as the entry point. 80% of all contacts are through the primary healthcare system. And it's through there, they don't like in Canada to be called gatekeepers, but they are gatekeepers. They make referrals to the hospital sector, to home care, to other services. So they do play that role. It is viewed across all provinces as a foundational piece, and it's needed to be for an effective and efficient healthcare system. And enhancements are needed to rebalance the system. They feel that there's too much emphasis right now on acute care. It's expensive. People are too reliant on emergency departments when they could actually be seen by a family physician for what we call ambulatory care sensitive conditions, which means it's a condition that could have been treated in the community. And we're seeing, we also have an aging population like the UK. Certain provinces have even more. Some of the eastern provinces like Nova Scotia and New Brunswick have quite an proportionally elderly population. And because we have really harsh winters and British Columbia is very mild, you see a lot of retirees moving there. So they're concerned about the growing prevalence of chronic conditions and complex conditions and the number of people with two or more. Definitely for us, one of the key things I think was also echoing from the UK, right provider, right time, and right place. All provinces are trying to look at that, and they're looking at trying to better integrate the primary healthcare sector with the rest of the services. All right. This is scary too, so I'm not going through it all. This is where I'm going to start now going into a little bit of history leading up to the Primary Healthcare Transition Fund. But what you see here is how many, some of these are provincial reports, and some of these are federal reports on the need to change the primary healthcare sector and the healthcare system in general. And primary healthcare came out as a #1 priority for change at that time. And in 2000, the middle one, in 2000, there was a First Ministers meeting, which is when the premiers of all the provinces meet with the Prime Minister. And they came to an agreement on healthcare, and the priority, one of them, was to change the way primary healthcare was being provided. And at that time, it was definitely fee-for-service, solo practice physician. That was the model. So, I think just before I go into this, or did I miss a slide? Yep. I'm really good with this thing, eh? I keep going too fast. It's not going forward, it's not going back. I want it to go back. Keep going back. One more. Okay, next one. Next. Okay. No, forward now. Okay. Next, number 10. Thank you. Okay, sorry about that. Primary Healthcare Transition Fund. It was an $800 million fund, and it was to accelerate the implementation of new models. But before I just get into what it was supposed to do, I'll tell you at the time, family medicine was in a crisis. We had a major drop in all provinces in the number of medical students choosing family practice. They heard it was overloaded. The volume was too high. At the same time, hospitals were being closed in the provinces. Mid-90s was time of economic constraints also, and hospitals were dealing with healthcare costs by closing hospital beds. So there was a download onto the primary healthcare sector. The family physicians were saying they didn't have the expertise or the backing support they needed to provide the care that they needed to provide. Especially, we also had deinstitutionalization of the mentally ill. So it was really a lot of pressure. It wasn't working well. People were complaining about wait times, not only for acute care procedures like hip replacement, knees, cardiac care. They were also complaining that they couldn't get access to a family physician, and it was taking too long. So this is why it was highlighted as a major priority. And so in the 2000 agreement, the accord between the premiers and the federal government, they identified primary health care as a priority, and the next day the federal government announced an $800 million fund to support the provinces. And it's had the following goals. We were to integrate the proportion of the population, increase the proportion of the population with access to a primary healthcare organization. And this was looking at, for the first time, having an organization that had a defined population. Before, with when it was fee-for-service solo practice, people chose where they went to the doctor. And they only knew the community that came in their door. They might be in a neighborhood, but their people might be coming to see them when they go to work. So therefore, they weren't actually in the neighborhood. It wasn't a defined population. So that's one of the goals that we wanted to look at, is having these primary healthcare organizations that have responsibility for a geographic area so that they could meet the needs, do the needs assessment, understand, and develop services that met the needs of their population. We wanted increased emphasis on health promotion, disease, and chronic disease management. Now, we wanted to expand 24/7 access, and this was seen at the time as a way to increase access to primary health care. We heard a lot of complaints that the offices are closed at 5, and on Friday afternoons, and I'm told to go to the emergency department. So the emergency departments are like, no, this has got to change. So expand 24/7 access other than the emergency department. And it was team-based care. For the first time, you heard a lot about team-based care. And so we're getting more at the right provider, right time, right person. And the last one was to facilitate coordination, and this was looking at the continuity of care and coordination across the sector. So those were the objectives. 75%, there were 5 envelopes. 75% of the money went to the provinces. The rest was multi-jurisdictional for some, and this was for economies of scale. So provinces could get together and decide on a priority that they wanted to work on, and they could do it together, and so therefore they weren't duplicating, and so we were definitely going to get economies of scale. And one of the ones for that was 24/7 helplines, and I'll get to that. Then from our level, my level, we had national initiatives that we thought would support the provinces in their work. And one of them was a primary healthcare indicator development initiative. It was a very big initiative. We consulted across the country, and we developed indicators that would measure quality, access, and performance of the primary healthcare system with respect to the type of care it had, and also chronic disease. And this had never been really done before. I mean, and we're still very weak on that. And then there was an envelope specific for our Aboriginal communities and for the official language, French in minority or English minority in other countries. At the same time, we had other initiatives going on. We funded, from the federal government, with the provinces and the universities, programs to develop curriculum for team-based care. Before, the schools of medicine and nursing and social work had all operated in silos. They trained their own professions in a specific way to work by themselves. This initiative was to develop curriculum and practice sites, collaborative practice sites, where students could learn to work as a team and then practice how they work as a team. And at the same time, in 2001, we announced Canada Health InfoWay. This is the organization, it's a nonprofit, independent organization that works with the provinces to implement electronic health record, telemedicine, telehealth, and the electronic medical record, all seen as necessary to support team-based care. So you can see there's a package of initiatives coming together. Okay. So, I'm just going to give you some examples. I'm not going through them all. They were varied. This is by no means a complete list. But for example, in the province of New Brunswick, with the money from the Primary Healthcare Transition Fund, they closed hospitals in rural areas, even and created what they call community health centers. This was defined population. They had a community advisory board. They had to meet the needs of the community and they provide team-based care, and the physicians were paid on salary. There was a lot of resistance at first. And a lot of what the Primary Healthcare Transition Fund did was manage this change. In Quebec, they continued, they had experimented with family medicine groups. This is groups of physicians, still paid fee for service, but they have incentives to work with nurses and to provide collaborative care. And they continued to implement those, and there was 100 more put in while they were getting the funding from the Primary Healthcare Transition Fund. In Ontario, it was similar. They went from family health groups, which are fee for service, and then they have family health networks that were capitation, and now you have the family health team, which is its newest model, but that is also it's a blended model. They get capitation plus incentives to do prevention, better chronic disease management, taking in vulnerable populations or people with complex issues. Alberta put in a 24/7 helpline. This is a nurse who staffs this line, and people can call anytime, get information, and there's an algorithm that she goes through and determines if she can help you or do you really need to go to emergency. What's very interesting, there's been a recent study that there's different health lines. Depending on the algorithm, they can increase use of emergency. So there's some caution in that, but there has been some good evaluations for different ones. And then in BC, they decided they already had a nurse line, 24/7 nurse line, and they decided to add pharmacists to that nurse line because they were getting a lot of questions about medication and combinations of medication. And they just took another tack. Instead of implementing teams, they worked with the family physicians, they created groups, and then they developed clinical practice guidelines to improve the quality of care that those physicians were providing. And they also based it on the Wagner chronic care model. I don't know if anyone know that, coming out of Washington, the state of Washington. It's the expanded chronic care model by Ed Wagner, and they implemented that collaboratives throughout their provinces. So that's just an example of the kind of thing that we did. Now, the fund was never expected to do it all. But, I have to say, the money only flowed from 2002 to 2006. It took both the federal government, now I'm a bureaucrat, so I can say this. It took the federal government plus the provincial governments about 2 years to get it in a framework about how the money would flow, what kind of agreements. All of the provinces needed to do strategic plans. They had to submit a proposal. They had to do needs assessment. So it was quite a long process before the money actually flowed. So these activities only occurred over 4 years. But it was definitely, I'm going to have to get my glasses here. Successful in fostering support in the development of team-based care. It was successful in implementing new strategies and evaluating them, especially when we're looking at collaborative care for chronic diseases. It brought together all the key stakeholders that had never been brought together before in such a way. Such as physician groups, nursing groups, psychologists, social workers, pharmacists, you name it. There was 14 national health professional groups that came together and sat down and started talking about what team-based care really means and how can we ensure that our professions work at their scope of practice to the top of their scope. And we found patient-provider satisfaction was found to increase with the innovative care, especially around collaborative care. But one of the things that was, I think, one of the more successful things was that there was a forum for the provinces to sit down and talk about what was working and what was not, and what their issues were. I mean, for the north, it's distance. I think you have it here. We have a very sparse population in the north, but they need healthcare services. It's difficult to get it. It's difficult to have family physicians work up there and stay up there. Most of it is nurse-led, and so how does that nurse get the support of the specialist or a family physician in other communities? So there's a lot of looking at telehealth care. I think the fund, one of the most important things of the fund is for the first time people actually saw that there was potential for transformation. It created the activity, it created the buzz so that people would sit down and talk about how it needed to change and what needed to happen. One of its key legacy pieces has been the indicator project I talked about, but also has been the training that happened, the curriculum development that happened in order to support team-based care. And as I said, for the first time we had these professionals coming together and really talking about what needed to change. It was a major cultural shift. We have seen an increase in the number of types and teams being implemented by the provinces. It's definitely a cultural shift. It was a change management piece, which is really hard when you're looking at fee-for-service solar practice who've been doing everything forever on their own and now having to work with other people and make this shift. So what did we learn? Oops. Okay, here we go. These are our challenges. 617, no, go back. This thing does never go back. 15. 14. Thank you. Okay, I'm going to have to learn how to do this next time. I think I won't stray too much on this. I think our foundational pieces were the teams. And the other part was a need for an IT structure. And this comes down to what I wanted to mention before, the timing. Some of this was all happening at the same time. And so the team-based care did not go as far as we wanted. We didn't get as many teams as we wanted. And some of the collaboration and integration we didn't get. And partly that was because we didn't have the IT structure in place. It was being developed at the same time. And it's big, and it's expensive, and it's difficult. And so for us, the condition of success was, it's a condition of success for moving forward is to finish our IT initiatives. And also the other piece that we think is foundational was the knowledge gathering and the evidence and the diffusion of the knowledge that we did through the evaluation of this fund. We couldn't have done it without leaders at all levels. The leadership, and I think the UK talked about that, the need for leadership, especially when you're looking at collaborative care and integration is essential. We've documented that. And we found that the projects that focused on health outcomes made the most shifts. So it seems to have that goal in mind, seems to be the thing that drives the change. Okay, so our current vision is very similar. This is not like a vision that's been agreed to by provinces and myself, and the federal government, I mean. But what I've done is I did a scan, and these are all the things that are being mentioned in the current plans of the provinces in order to change the primary healthcare sector. They want it to be seamless, patient-centered, integrated, and coordinated. Team-based care is still there. Health promotion is taking a much higher profile. Chronic disease management also. Integration, we're weak on that. Much more needs to be done. We've made a lot of progress, but we're not there yet. Determinants of health. How does a primary healthcare organization address the determinants of health? This is a newer discussion that's coming back into play. It's old, we had it before, but now it's really taking off. And the other thing I think that the UK also mentioned is we need to measure the system. Now, we have some innovative models that are measuring what's going on in the sector and evaluating and accountable and looking at quality improvement, but it's not widespread. And then the evidence-based decision-making based on clinical practice guidelines. So what's happening in Canada, I don't know if it happens here, but the College of Family Physicians may develop a guideline around diabetes, but getting it diffused out to all the family practice is difficult, and the uptake is even more difficult. So that's one thing that people are looking at. I was asked to talk about integration, but For us, definitely the most successful innovations that we have in integration have been those that have been able to pool the funds from several envelopes. And also having the structure in place. But the UK had a bit of a different spin on that, and he feels that leadership is the key thing. I think it is as well, because the projects that we have been successful in have had the leadership at the local level. But one of the things that we have heard is that funding coming through different envelopes, if it's a hospital funding, this is primary healthcare funding, this is social work funding, and if we can't pool those resources, then the integration can fall apart. So that's one of the things we're hearing, but it's new. It's not, I don't have a lot of studies on that. And our challenges, as I said, integration. Patients are not sufficiently engaged. We're hearing that from the provinces. They're really looking to increase self-management and self-care. They see this as much more cost-efficient, but also effective care if the patient is able to take along and monitor their chronic condition. This will need e-health technology. They're looking at portals. Some people are, we haven't gone to mobile yet, but it keeps surfacing at conferences and meetings. What's the role of mobile health, and how can a patient use that to communicate with their physician or nurse? In Ontario, they're looking at nurse-led clinics. So that's a complete move away from just physician-led, and okay, thank you. And there's continued adoption of different remuneration models. We have fee-for-service with incentives, we have capitation, we have salary. That continues. So we've had, still the majority of physicians are funded through fee-for-service. It has been increasing over the last few years. I think it's now about 34%. Provinces would like to see it higher, so there's continued work in that area. And the uptake of electronic medical records. Now, our Canada Health InfoWay focused on developing the back foundational pieces of the electronic health record, and you know, the databases for the drug system, the databases for the lab system, the client registry, the client provider, all those are in place now, and now it's focusing on the electronic medical record, which is in the doctor's office for the team. But the uptake right now is not as fast as they would like. And I think for us, we need more evaluation in Canada and more performance measurement of what's happening in primary healthcare by all the providers. I'll skip that one. I'll go right here. Just some recent projects. There is the Canadian Institutes of Health Research has just announced a $30 million project to look at implementing teams for those who are vulnerable and with chronic conditions. And then they're going to do rigorous evaluation, because that's one of the things we really don't know, what works and what does work, who needs a team and who does not. Initially, the philosophy way back in 2000 was team-based for everybody, but now we realize that's not the case, and so we need to look at that. Canadian Institute for Health Information. I'm going to talk about the primary healthcare voluntary reporting system. This is a reporting system that right now we have a few physicians participating in, and they're measuring quality improvement. It's getting some very good results. It's very, very early. They would like to see more physicians volunteering on it, but the physician gets a report back on the data that he sends in. He gets a report back about himself and about his practice. And as I said, Canada Health InfoWay is really focusing on implementing the electronic medical record for team-based care. And I think that's it. I don't think I will really worry about that one. I just want to say that from what we learned from the fund itself is that primary healthcare should always be changing and evolving. A lot of people thought, well, you have the fund, you've made the change and now it's done, but it's not. And so it should always be changing and be agile and be dynamic so we can meet the needs of its community, which is forever changing. For us, we learned that the process for change management, managing that change in that culture shift was more important, I think, than actually just implementing the teams. It was the discussion that took place with that fund that has had the most lasting impact. And even though the teams have continued to expand, it was that discussion that brought people together that's really continuing to make the change. And I think we realize now if we were to do it again, we would need to know what the conditions are for success. And we didn't have that. We had an idea, we had a vision of where we wanted to go, but we didn't actually sit down and analyze what were the conditions of success. I think that's where I'll stop. Thank you very much.